That's good? Okay. All right, well, welcome back. Let's not fall asleep. If so, we can do a stretch after Dr. Hassell or in between. All right, so next we'll have Dr. Kathryn Hassell. Dr. Hassell is the professor of medicine in the Division of Hematology at the University of Colorado, Denver. She is the director of the Colorado Sickle Cell Treatment and Research Center. She attended the University of Minnesota School of Medicine and completed her internal medicine residency at the University of North Carolina, Chapel Hill. After finishing her hematology oncology fellowship at the University of Colorado, Denver, she has spent over 20 years caring for adults living with sickle cell disease. Her national efforts have included establishment of the Sickle Cell Adult Provider Network and serving at the National Heart, Lung, and Blood Institute at the NIH for 4 years in the Blood Disorders Division. Dr. Hassell is involved in a number of national clinical research and health services projects in sickle cell and thalassemia. Welcome, Dr. Hassell.
I'll take it at the end. I'm not, following Dr. Sherman is like, oh, really? Following my, I don't have a sickle cell or... Anyway, all right. Well, and I do appreciate I'm fighting the postprandial insulin surge, so it's okay as long as you just don't snore too loudly that your seatmate can't hear. We're really okay. So I was given this topic. ACE is like, just talk about the standard of care for sickle cell. We hope to have entire medical school courses about this very issue. But I thought today I would first give you my disclosures, which there aren't any financial or industry-based disclosures for this presentation. I'm going to mention hydroxyurea for children, which is off-label by the FDA. And another disclosure, and I think part of why maybe ACE picked my name off of what was an otherwise a long list, is that I am a member of the NHLBI's guideline panel, which is a work in progress that I'll allude to. And I suspect that, I don't know what let me just tell you now. Y'all had a chance to publicly comment on them last fall. We had 1,800 comments. We attempted to adjust and incorporate or completely modify some sections. I really don't know what they're going to say, although I know the basis of them because they're now being reviewed by both the agency, NHLBI, and by professional organizations. So they are still a work in progress. So my answer to what they will say is hold, please, because they will be out hopefully this summer. But I will incorporate sort of a gestalt about where I think they're going. And that's part of a bias, honestly, that I bring to the presentation, which is why it's on this slide. So my objectives today are to start us off with some food for thought about what it means to have a standard of care. Because I went to Dr. Google, a great source of information, and found some very interesting things that I'll briefly share with you, including things like evidence-based guidelines and quality indicators. Then what I want to do is review for you in various ages of life for individuals living with sickle cell disease the common approaches to management. Because I anticipate, I hope, a vigorous discussion, especially after Dr. Bell's presentation about acute management, about, well, but I do it this way, or haven't you tried that, or shouldn't we be doing this? And the answer, as you'll see, is that there's not such a large body of knowledge, that there's something absolutely, if you do it that way, you're wrong, or if we don't incorporate it, that's incorrect, or if we do it that way, that makes us intrinsically doing the right thing. So there's a lot of room for play here, and I'm going to talk about what's commonly done, the big high notes across the lifespan for those living with sickle cell. And because Dr. Bell is going to talk about acute management issues, I'm going to talk about the chronic, day-to-day sort of in-clinic issues and not acute management issues. I'm happy to field calls, especially after Dr. Bell's presentation. I can envision a part of a session, I hope, that answers questions about very specific aspects of the disease for you. And all along the way, I'm going to remind you about basic guiding principles as we heard in the presentation earlier about what happens in sickle cell disease, the B's. I love that blockade. That's awesome. Because when we don't have evidence, we have to reason on what we ought to do or what we think would work. And I think that's a valid thing in the absence of evidence. And then I'll remind you that these are folks who are humans that have genes and predispositions to all kinds of other things, not just their sickle cell and complications therein. And so we have to remember a holistic approach about all aspects of their health and all things that are good for everybody who's alive at age 52 or needs something done at the age of 5. That we have to remember good medical practice is a part of, quote, standard of care. Okay, so if you talk to a lawyer, what they say the standard of care, when you say that you've met the standard of care, is it's the watchfulness, attention, and caution and prudence that a reasonable person would exercise in the same circumstances. So if you talk about a medical, legal standard of care, it's the level at which the average prudent provider, think about that, those of you living with the disease who are not happy with your provider. We're talking about what the average person does, not the exceptional, not necessarily the expert. What the average person would do in a given community, it is how similarly qualified practitioners would have managed the patient's care under the same or similar circumstances. I would argue, despite our fears as providers about the law, they have a pretty low bar in many ways, because it depends upon what the community clinic down the road does. And I'm not saying intrinsically that's bad in any field, but keep that in mind. That's what the legal standard of care. In Indianapolis, just by the way, since we're here, you are malpracticing unless you provide reasonable care and skill provided by providing health care to a patient as would a reasonably careful, skillful, and prudent health care provider acting under the same or similar circumstances. But this is sort of when someone says standard of care and they're thinking like a lawyer, this is what they're thinking. What most providers need, says Dr. Google, is a diagnostic and treatment process that a clinician should follow for a certain type of patient illness or clinical circumstance. And that's a functional way that I think most of us in the room would think about it. What do the client-patient websites say? A standard of care is a formal diagnostic and treatment process a doctor will follow for a patient with certain set of symptoms for a specific illness. That standard will follow guidelines and protocols that experts would agree with is most appropriate. So quite different from the lawyers who we often vilify. They are looking for expertise in a way that you went to not just med school, but subspecialty school, and that there's protocols that are evidence-based or at least best practices. So when we talk about what's the standard of care, or in the question, well, that sounds like a standard of care. Well, we'll have to see. Because in sickle cell disease, the community around you by which you're judged by the lawyers may not know anything about sickle cell disease. And so that's a pretty low bar, I would argue. And we, as a collective medical enterprise, owe ourselves to bring up that standard of care to some basic levels, the common approaches that I'll talk about. Patients and providers expect that the standards that are touted, sent to you by a professional society, a guideline that's published, is evidence-based. And I got to tell you, living through the last 4 years of guidelines, there is very little evidence for what we do in sickle cell. Doesn't make it wrong. But if we are saying or believing that's based on evidence, we have to be circumspect about that. And then as importantly, in the absence of evidence, there is experts. There are people who have spent their lives taking care of individuals with sickle cell, and that observation is evidence. But try and find the expert sometimes. They're busy, they're outstate, and when you ask 2 or 3 experts, you might get 2 or 3 different answers because there aren't data. So this is just a context for what I'm going to outline today, mostly because when I'm on these guideline calls and a famous person says, well, I always do this, I'm like, crap, I never do that. It's because there isn't always the certainty that we place in it. And so my goal today is to look at the common practices to see how much evidence there is, or can we reason to a place that it makes sense. And you're going to like, well, I knew all this, it's all very basic, but hopefully you'll be seeing it in sort of a different context. Now, what about evidence-based guidelines? So Dr. Sackett characterized this as conscientious, explicit, judicious use of the current best evidence in making decisions. And they even have these systems. GRADE is this one of them that looks at all the evidence. And we think about studies, we think about New England Journal, we think about JAMA, we think about randomized controlled trials. And in fact, where you get to the sole statement of informed medical commentators is grade 4 out of 5. 1, 2, and 3 are big randomized trials, or at least big studies, of which there are very few in sickle cell disease. And at the bottom is grade 5. You shouldn't even talk about it because there's no evidence of any kind. And hopefully we aren't doing very much in sickle cell in that regard. And then finally, my last part of the introductory comments. Oh, and let me just comment. So there are sickle cell guidelines. So there is the NHLBI guidelines. I still hear people quoting those from 2002. And I knew someone who wrote one of the chapters. And he wrote a 4-page diatribe back to the NHLBI because he wrote the chapter as a sole author, as a single opinion, by the way, with which we would have all agreed with this chapter. And a very well-meaning, very smart non-sickle cell doctor edited it to change its meaning. But that's what's out there. And so that document is sole author, smart, wise people doing the best they can from over 10 years ago. The American Pain Society in 1999 had guidelines for how to manage acute and chronic pain, except there's no chronic pain management in that document. It's more than 10 years old, and the reason there's a sunset is because the current standard is that if they're more than 5 years old, they are archived. You should not use them. They are labeled with archives, do not use. So we really are lacking for standards, or at least guidelines around what should be good common practices in sickle cell disease. And so coming soon are the new guidelines, much awaited. And what I will tell you is that there's a lot of recognize this is a problem in sickle cell, and if you recognize it, call a doctor who knows, without specificity in some of the very sticky issues that we deal with in sickle cell disease. So the bottom line is, as we move forward with the rest of my presentation, I hope to give you a sense of how we would look from 1,000 feet at what are the big and important issues in management of sickle cell disease in 2013. And the reason we're going to be driven to this is because in the world of the Affordable Care Act, is that things are going to be tied to pay for performance, improving quality, as is appropriate, I think, broadly. But the definition of having a quality indicator is that the norms and clinical the criteria, the standards, and other qualitative measures that are used in determining the quality of health care. So it's not even that we agree anymore, it's that everyone actually gets it and that the health care gets better. And that's the narrowest of targets. And actually what I'm going to do is comment on a recent effort and a paper I'd encourage you to get a copy of. And I have the full citation in just a minute. So Jason Wang convened a group of experts in sickle cell disease focused on pediatric care. What is quality care in sickle cell disease? And they devised from the literature and the old guidelines and all that, what are the 82 kinds of things that are potential measures? And this group, over a process called the Delphi process, adopted 41 quality measures. Things that if you don't do it, there's something wrong with your practice, and you should strive to do it. And by the way, therefore, it should be funded, and that the insurers should help to cover it. So a different sort of focus than just common practices. And what they found is that they could only adopt 41 because there was only evidence for 41 of them. And even of those, only 17% of them were based on the randomized trials that we use in medicine all the time. 30% had other evidence, and half of them were because they saw a few cases once and decided that's what you do for it. So even in this very narrowly focused emphasis on what's high quality, we're still in an arena where in sickle cell disease there's room for discussion about what is the best approach. But I'm going to focus on this paper in particular. And then in the adult world, much less has been done. And I picked this because of the title, not because I'm a co-author. An evidence-based approach to the treatment of adults with sickle cell, where a similar process was done, although not so formally. So you're going to see these two references, Lautenberg and Wang, as I go through and characterize what would be high quality care or important things to do for individuals with sickle cell disease, with this all as a background. So we're going to look at infancy and early childhood, middle childhood into adolescence, and then adulthood. I'm going to talk some about disease-modifying therapies and their application, not transfusion explicitly. Again, Dr. Bell, I think, will touch on some of that. And not acute pain management. I'm not shying away from it. I'd welcome a conversation, but it's in the acute section, I think, for a formal presentation, and we'll talk about it. And throughout, I'm going to point out that individual preference has to weigh for anything. You always need to engage the client in their perspective about whether or not, we heard a question earlier from one of the young ladies, what if I'm worried about the side effects? How much treatment should I have my children receive if they haven't had a problem yet, that sort of thing. And then type of sickle cell disease matters for some of these quality measures. Okay, probably the world's longest introduction, but hopefully food for thought, because there's room for dialogue about what I say maybe you ought to do, or even Wang says in his paper, versus what you might do or what may not make sense in a given practice. So this has already been discussed. Everyone now screens for sickle cell disease. I'm proud to say in Colorado we've done it since '78. Done it for a really long time. The reason that you're doing it is you're looking for FS on the newborn screen, which means they either have SS or S beta 0 thalassemia. And we don't want to wait until they get the hand-foot syndrome. You want to find them ahead of time. Why is that? The spleen, and again, I won't spend a lot of time. You can get splenic sequestration. It'll enlarge and suck down all their blood counts and lead to shock and potentially death without rescue. Or it eventually leads to infarction in SS and S beta 0 thalassemia, so FS on newborn screen, and then you can get overwhelming pneumococcal infection. Hopefully familiar territory already commented on. The reason, as you can see, is there's actually evidence. I'm starting with the strong stuff here, fortunately coinciding with the course in life. So this is a very blurry picture. I'm sorry about that. Looking at prophylactic penicillin, you've seen the data presented by earlier this morning. The recommendation is to start at age 2 to 3 months of life until the age of 5. Why do we start that early? Because you start seeing pneumococcal sepsis as early as 2 to 3 months based on these data. Why do we stop at 5? Because PROPS 2 suggested there was no continued benefit between the ages of 5 and 10. Randomized controlled data, this is what we look for, this is what we do in medicine. And so it makes some sense at the beginning of age 2 to 3 months to start and to stop at the age of 5. Now, I have adults taking penicillin until they're 25. Is that wrong? No, not necessarily, but this is what the data support. And so what are the quality indicators that this group convened and said from the Wang paper? So all children with FS on the initial newborn screen, don't wait to figure out if there's a beta 0 or another S, should start something, e.g., for example, penicillin. I've been engaged in and witnessed some vigorous conversation about all we're doing is breeding penicillin resistant and half the bugs are resistant anyway. Why are you recommending prophylactic penicillin? Well, they aren't in this most contemporary quality indicator. Something. Now, what is that something? I don't know. We haven't studied anything else. But something should begin because we know that if you don't start, and penicillin is still the most commonly used, you're going to end up perhaps with overwhelming infection in an infant. Children with sickle cell anemia who are younger than 5 should receive some kind of antibiotic prophylaxis. And this would define quality of care in your practice, something to strive for as you develop a program if you're going to treat infants with sickle cell disease. But the 10 VK per se isn't necessarily what you have to be tied to if there's something else that you think works better or comes along. And then children have fever of greater than 38.5. What about 38.3? 38.7? Again, you can write things down, but there isn't any data that says it has to be 38.5. But the principle is a fever, however you define that, should be given parenteral broad-spectrum antibiotic therapy. In my hospital, people go crazy if it's not ceftriaxone. Okay, it's what you have on hand, what the child isn't allergic to. It's the principles here that I think we're sort of evolving towards, and within 60 minutes of triage because of the urgency of the infection. In terms of prevention, immunizations are recommended. The quality indicators that came up from the panel were children with sickle cell disease to complete the pneumococcal 7 vaccination, the 23 per CDC guidelines. So this is a good example of a recommendation that lives in perpetuity, because if the CDC guidelines change, so does this recommendation. It depends on what the CDC might recommend for asplenic or those who are impending asplenia with sickle cell disease. Splenic sequestration. So this is, as was described earlier, acute expansion of the spleen with a very low hemoglobin. There's a phenomenon called rebound, where if you transfuse above and beyond and give excessive transfusions, eventually some of those intact red cells will come back into the circulation and get a rebound that's too high, and you can increase viscosity in young children. But you should consider certainly supporting that child with at least some transfusion, and of course with fluids and other things as necessary for shock. So how much? How high? There's no indicator by this paper. Now, that's not because they don't think splenic sequestration is important. It's not that they don't think it's important to consider a transfusion of some amount. But ask for pediatric hematologists how much to give, and they'll give you 4 different answers potentially. And should you take the spleen out if they've had how many? 1 episode, 2 episodes, 3 episodes? Certainly people are reticent to do so before the age of 5. But it's been done. Should you do a chronic transfusion program for splenectomy? The answer is I think that's a potentially viable option. Are any of these, quote, standard of care? If you violate, you're in trouble. It's what you should strive for. I don't have data about that yet, but they are considerations. They do have other quality indicators in early infancy, so getting to our presentation, parents with children with sickle cell disease should be given a written plan for access to care during acute complication or illness. There's no evidence for that, but that just gets at the medical home and common sense, I think. All children with a newborn screen indicative of sickle cell disease should have confirmatory testing. In some states that's done in the state newborn screening program, but sometimes we forget that's left to a community clinic or a primary care provider that may not be cognizant of the need for that. And all children should be offered, parents of children should be offered genetic counseling within 6 months of the child's diagnosis. Now, do we have any data that if you counsel a set of parents before the first child is 6 months of age that say the unplanned birth rate of sickle cell anemia children goes down subsequently? No. But does it make sense to offer this? I think so, although one could reasonably argue, as we talked about after the last presentation, that there's so much knowledge that they're being provided that they may not process it well. At very least, it ought to be reiterated. But this was considered to be important by a panel of experts as a marker of high quality in your practice. And even though we have limited evidence, this is from a paper I did a few years ago, I suggest that all of this collectively, at least in terms of the care for the infant, is working. So the dotted line is the age at death as a cross-section. When people died in 1979 with sickle cell disease, very confounded data. I accept that. But the principle is, in 1979, there was a lot of people who died in the less than 5 years of age. And by the time you look in 2006, virtually none of the people who died of sickle cell were little kids. And I think that that follows a lot of things, including newborn screening, prophylactic penicillin, improving immunization, better patient education. So there's evidence that this works. Enough to say, yep, the things we just talked about, I think, would give a sense of high quality and good care for infants with sickle cell disease. As you're well aware, the next thing as you enter into childhood, of course, is stroke. And here again, we have data. We've demonstrated that you can detect increased flow with the transcranial Doppler. And this is associated with the area of vascular narrowing. And if you have a high TCD greater than 200, you can see the curve that drops like a staircase, versus those that have normal values for TCD, and the risk of stroke is very low. You could prevent that, as was shown in the STOP study. You can see that the top curve, the top line really, the STOP bar, demonstrated virtually no strokes in kids who were transfused versus the rate in the untransfused groups. And the data are presented there, and it lasted for as long as 65 months. Data, wow, data, very good. Can you stop? We answered that question. Can you stop this transfusion? Apparently not in kids. When they did stop, kids reverted and they started to have recurrent strokes. Both of those were endpoints. There were only 2 strokes, but other kids went back into a risk group. So it's clear that we shouldn't stop, at least in the kids that they followed for those couple of years. And it was actually closed early before they hit the endpoint because of the recurrence, as you heard about. So what's the quality indicator that the group looking at the body of evidence thought? So the children with sickle cell disease who are 2 years or older should be screened yearly with a TCD. Why 2? Because that was the definition in the study. Those are the data that we have. If it's a conditional screen, they recommended a second one be performed in 3 months, and they should be placed on a chronic transfusion program if found to have an increased time average finding of greater than 200 meters per second. So based on this publication, a quality indicator is that the kids who have had a TCD and it's been repeated should be on a blood transfusion. Now, I think again, back to the point I made in one of the earlier slides, you have to incorporate family preference. There are vagaries to transfusion. There are challenges, including the iron overload that we heard discussed earlier. But this is now sits in the literature as evidence of quality care in the care of young children with sickle cell disease. And there's no advice about when you can stop, because no one's explored that end much like they did with prophylactic penicillin. I would tell you as an adult provider, I never stop. Every adult provider I work with, now to be fair, I'm in academics, we hang together at the meetings, no one stops it in adulthood unless they're forced to by virtue of whatever, insurance or patient preference, or they go off to school, or they choose not to continue. But I think we don't have evidence about when you can stop, and it doesn't say so, but I think there isn't evidence that you ever can stop. But that's me, and that's just people I know. Is that a quality indicator? Is that a standard of care to not stop? I'd like it to be so, but can I prove it to you or to an insurer? Not yet. Just a reminder, if you have kids on transfusion, they do have quality indicators in that regard. Children with sickle cell disease who are 2 years or older are receiving a chronic transfusion program that should have a comprehensive annual screening assessment for iron overload. They do not, well, and here we go, should receive chelation therapy to maintain a ferritin at a certain level, iron at 7 milligrams per gram dry rate by biopsy or MRI. So pretty high bar, some would say. The thalassemia community believes you ought to make that liver iron concentration nearly normal, 2 to 3, 1 to 2 being normal, and not just let them sit up at 5 to 7. But you notice they don't say an insurer should buy an MRI or a liver biopsy. They've left it flexible to reflect whatever you can attain to assure that you know what the iron status is. that might include biopsy or MRI, as it says. The second standard is a huge controversy in the blood bank community, which is if you're going to give a transfusion to sickle cell disease really for any indication, it should be matched for ABO, of course, the RH factor, and then CD, E, and Kel. Now, at my institution for 30 years, we've matched for 17 minor antigens. I hadn't even thought about this when I lived in the rarefied, literally, air of Denver. But this is a consistently recommended quality indicator. If your blood bank is giving a transfusion that isn't matched for CD and Kel, theoretically they're giving low quality care. But blood banks will say, well, I need to find the right donors. It's an incredible expense. Who's going to pay for the blood? I don't get paid for the blood I get based on Medicaid reimbursement. I think it's a great marker of quality. Can anyone prove it matters? That's less clear. Versus waiting till they form one antibody and then really scrambling to match beyond. No one's done the randomized control trials. And then they should have an extended phenotype documented at least, so once they make that first antibody, as most blood banks do, and you shift to matching for all of the antibodies, that you know what other antigens they have so you can better perform that matching procedure. So this is a quality indicator. This may be adopted by insurers and Medicaid. And the only good thing about that is if it's true, then maybe they'll start paying for the cost of the quality indicator to get the appropriate blood. In kids who have a stroke, silent infarct, or a high TCD, they should have an age-appropriate neurocognitive evaluation by a psychologist. Do you folks here in Indianapolis, are you guys able to get neurocog testing pretty readily for your kids? We, kind of plus minus, I'd say, in Colorado, and I think it probably varies around the country. It notes that all children should be screened annually, now not without stroke, but just all kids, with a parent-reported measure of adaptive functioning. So look to see how are they doing, and if they have an abnormal adaptive functioning score, and I don't know, I do adults, so I don't know anything about the score per se, but they've isolated this one as being indicative, that they should undergo formal neurocognitive testing and neuroimaging. I must say my sense is generally you can make a case for children, unlike us adults, for getting the appropriate testing when you have something like an adaptive score that's poor, or you demonstrate silent infarcts. So this, I think, is probably achievable to demonstrate you're doing high quality practice. It certainly was felt to be important by this panel. And then I'll remind you that, of course, sickle cell disease, as we already heard about with the bees blocking everywhere, is that many organs are damaged. And you're familiar with these: retinopathy, chronic lung disease, hip disease, AVN of the shoulders as well. The brain, of course, we just talked about in the spleen. The kidneys, the bone, there's leg ulcers. Interestingly, the liver is relatively spared unless we poison it with iron or we give hepatitis C. And the heart, in the sense for the adult providers in the room, they don't get coronary heart attack, those kinds of diseases, although there can be changes in the heart. But it is a multifaceted thing, and some of these things do begin in childhood, which is where we're still talking. So one of the primary manifestations of lung disease in children broadly is asthma. And if you have asthma, it's thought to have an interplay, of course, with your sickle cell disease. The clinical diagnosis of asthma ranges all over the map from 2 to 50% of sickle cell children. You can see this clinical, and if you have the clinical diagnosis of asthma, and if you do PFTs and you see obstruction in the PFTs, that this is associated with an increased risk for chest syndrome and for pain events. And there's even an airway hyperreactivity that you can diagnose that may or may not be actually asthma. And that might be really common. So if you go looking, you can find things. So what's the quality indicator around asthma and sickle cell? In children with sickle cell disease, you should screen them by history. They don't recommend PFTs. They recommend asking the right history. I'm not a pediatrician, and I trust there's some sensitivity and specificity to the questions you can ask, but by history. And if you find a child who has asthma, or you think has asthma, of course you should proceed with the appropriate diagnoses, and then they should have a written asthma action plan, which is true of any child, even if they don't have sickle cell disease. And routine PFTs are not recommended. Why? I'm only speculating. I didn't sit on that panel. But there's really no evidence that screening a child who's well, just because they have sickle cell disease, is going to increase your yield in a way that you should do it for every child. Now you're like, wait, I do it every year. Don't tell me that. I'm just letting you know what the evidence has supported for a quality indicator. It doesn't mean that it can't be a good practice. It doesn't mean that it can't be something that makes sense in your practice. but just to give you a sense of what people have looked at the evidence and have recommended. They have some other quality indicators in childhood, which is priapism. They note it may occur in children as young as 3 years of age. The prevalence may approach 70 to 80%. If you look at through the first 20 years of life, and certainly in the adult world, it's not rare. So their quality indicator was to have education about priapism and its treatment options. It should be provided to parents and their male children by age 5. So they don't want you to do PFTs, but they want to make sure that you can document that you've talked to a parent about priapism by the time the child has reached age 5, which seems like a good plan to me, along with the other things that they need to hear about. They note that children with sickle cell disease should have a comprehensive evaluation, including a pulse ox, a CBC, and a reticulocyte count at least annually. No chemistries were recommended. Parent with sickle cell disease should be given a written plan how to access care, acute complications that I alluded to. And if children have early stage AVN, they don't recommend screening for it, but if you happen to find that they have AVN, they should have an orthopedic consultation and a physical therapy evaluation. These are not meant to be the sum total of everything you do in your practice, but these you could argue are sort of the bare bones, what characterizes high quality, at least in the opinion of this panel, as convened by Wang. Now, in childhood still, there's at least 3 other issues that I'm aware of, and I hear when we do at our center, we have both adult and peds care kind of together, and the practitioners work together, at least in case conferences. So screening for retinopathy, dilated retinal examinations, since we know retinopathy can occur, screening for pulmonary hypertension, or at least doing an echo, and then screening for renal disease. None of these issues are addressed in that quality paper. So for retinopathy, we know this is an onset of the condition. In SC disease, it appears to onset sooner than in SS. It looks like by the curves, these are Jamaican data that picks up somewhere between the ages of 5 and 10 for SC disease, so it seems reasonable to start with an SC child between the ages of 5 and 10 with an annual ophthalmologic examination. With SS, I think one of his slides said greater than 10. You can see what the epidemiology is, at least in the Jamaican paper. There's anecdotal success with laser therapy, no randomized data, large case series, but it probably works even in childhood. Why isn't there a quality indicator? I don't know. Makes some sense to me, but perhaps they judged that the evidence wasn't there. And I bet they fought long and hard behind closed doors about at what age. Because I don't think we know. As soon as they're young enough to sit and tolerate drops to be seen, I don't know. I think the epidemiology gives us some guidance for good practice, at least. But that's the nature of the information we have. A very controversial area, of course, is whether you should do an echo for individuals with sickle cell disease. An elevated tricuspid regurgitant jet velocity, so evidence that you got backwash through the tricuspid valve, can be an indicator of pulmonary hypertension. And in adults, if it's greater than 2.5 centimeters per second, when they're well, and if you repeat it and really it's there a couple of times, it's associated with early mortality. I'll come back to this in the adult section in just a few minutes. But when you find this in children, there is no increased death rate. The very same numerical values that you find in adults are not associated with death in children. And you can find it pretty prevalently. If you look at the SS beta zero thal, the so-called sickle cell anemia, in up to 30% of some case series, you can find a high TR jet. And in only a very much smaller percentage, 0.3%, will you find a value of greater than 3 meters per second. In an SC disease and S beta plus cell, you probably won't find it in populations until they enter adolescence and early adulthood. And more importantly, if you say, but that's okay, 0.3% is important to me, 5% is important to me, do bear in mind that you're going to find the abnormality at up to 30%, and then you take them to right heart cath. 30% of your 5-year-olds, 10-year-olds, need to go to right heart cath before you can appropriately interpret this marker to know exactly what it means. And so once you open that Pandora's box, you need to think carefully about what you would want to do. Now, some people say, oh, but Dr. Hassell, I'll put that kid on transfusion. No one's ever done that to prove that it makes any difference. Certainly they're not going to die in the next 15 years because the data say they're not going to. And what are you impacting? What are you changing? We don't know. And so I think that that's the challenge in childhood for sure about doing a routine echo, especially if the kids are asymptomatic. And so is there a quality indicator? I wrote blank just so the organizers weren't worried that I skipped a slide or something. It is blank. There is nothing, there's no comment. Why not? I can speculate talking to some of the panelists afterwards. There's no evidence that proves that if you find it, you should do anything about it, and if you do something about it, that it makes any difference in the asymptomatic child. If a child's symptomatic, it should join the evaluation of why someone has cardiac exercise intolerance, breathlessness, or other symptomatology, because it could be present, although it's really quite relatively rarer in children. And if there are signs or symptoms, you need to go the whole way, which includes right heart cath, to be fully evaluated. And we have children with full-on pulmonary hypertension who are on very potent medications, as are other children with pulmonary hypertension. But you can't stop halfway if you're going to step down this pathway. And then finally, an area that does become an issue, especially later in childhood, is microalbuminuria or proteinuria, perhaps as a precursor, as in diabetes, for ultimately developing kidney disease. And the microalbuminuria, if not overt proteinuria, occurs in 20% of kids less than 20 years of age and can be seen as early as 5 years of age. And there are studies that look at short-term enalapril or lisinopril, which shows that you can make the proteinuria go away for as long as you give them the medication. Now, the problem is we can adapt from diabetes and assume that means they won't ever be on dialysis when they're in my service, but we have no idea. We actually don't know. And it's confounded by the fact that you had to discontinue some of the medication in these kids for side effects like hyperkalemia. So it's enticing. It's just a dipstick. There you go. And maybe you should, well, I know you should, look for other causes. These children aren't immune to other forms of proteinuria from other kinds of kidney disease. But once again, the guidelines are blank, or at least quality indicators. And I'd speculate that there's no evidence that starting a 5-year-old on lisinopril is going to change what happens to that child, to the good necessarily at least, when they're 25. Now, if you find overt proteinuria, you should work them up for all the childhood things that can get them there. But should you screen every child that walks through your door? I don't actually have a problem with that. But in terms of people who sit and look at the evidence, they are less certain about that because the intervention, for example, might lead to hyperkalemia. And already there's angst about the blood pressures are usually not high, and now we're giving an antihypertensive on top of that. So it's a complex decision. So I'm not here to say if you're doing it now, please stop, you're in trouble. But know that the level of evidence that supports that practice is based on collective experience and expertise, and not necessarily proof that you're intrinsically doing good. And then they do point out about routine health care, though, that age-appropriate growth curves need to be used, that you should give an annual immunization per CDC guidelines. If the CDC guidelines ever change, so do these. They've cleverly tied it to that. If they have blood pressure above the 95th percentile for the child's age, they should be evaluated. That makes sense. Transition planning should be in place. That's true for any child in any healthcare setting. And adolescents should be counseled regarding transition. Notice I don't say you should provide transition or that the quality indicators that you have someone to transition to. I wish they'd make that a quality indicator. But it's to address it in the context of your pediatric practice. And so that's what they comment. But I'll remind you then we enter into the adult world. So they do successfully come on over or unsuccessfully coming over, but either way, they age into adulthood. And the same issues are there, it's just that they've now had 20 to 25 years to brew. So what do we know about what's quality health care for adults living with sickle cell disease? Well, first of all, we know that there's a huge burden of chronic disease and chronic organ damage. And this is just the MSH follow-up study when they got autopsies and they looked at the causes of death. You can see that hepatic disease, most usually iron overload or Hep C, renal disease, cardiovascular disease characterized by a hypertrophy left ventricle, pulmonary disease, and actually the causes of death were more chronic, as we heard about in the panel discussion, right? You don't die of the sickle cell, you die of what it does to you, and less so in the adult population for infection and death during crisis itself. And this is an older autopsy study that showed chronic infarcts were seen in the lungs, were seen in the kidneys, there was an incidence of stroke in adulthood, and then liver failure, again, usually secondary. And the heart disease thing was while cardiomegaly is present, they don't usually die of traditional heart failure. And so in adults, they're not just, I like to turn this phrase around on my pediatric colleagues, kids are not just little adults. Well, adults are not just grown-up children, especially in sickle cell disease. They have had far more time, unfortunately, to develop a different spectrum or level of manifestations of chronic complications. And the challenges here, before I launch into what I would offer are things to consider in adult care, is that there's almost no evidence other than the MSH trial and interventional trials. And this just listed from Lautenberg's paper the 3 or 4 trials that were available. And there are no quality indicators. That very same process I'd love to convene with adult providers, as was done for Jason Wang's paper. And so principles may be helpful. Reasoning, what makes sense given what organs are damaged and what we do from other disease states. So let's just take it in the order the kids go though. I'll remind you that especially with SC and S-beta plus cell, you can still have a spleen in adulthood. We do see splenic sequestration and splenic infarction, but we don't give prophylactic penicillin. And I thought it was interesting because in the guideline panel, one person said, well, I give all my SC kids penicillin at birth. And everyone does. I'm like, really? We don't. And is it wrong to? I don't think so. And then they said if you have to do a splenectomy in the child, they should take prophylactic penicillin drops or pills for life. I don't have a single splenectomized adult that I've ever given penicillin prophylaxis for whatever the reason for their splenectomy, trauma, cancer. It's an interesting thing that we think about it differently in the adult world. When we have adult onset issues with the spleen, including for non-sickle cell related, it's not clear if you should give empiric antibiotic therapy. I did so for a long time, and my colleagues were like, really? I'm like, yeah, really, they look sick. I mean, no one discourages it, but there are no data like we have for children about what you should do with fever and sickle cell disease. My principle is to give some IV antibiotic, because usually they're in the hospital when they're sick enough with their fever until at least the blood cultures are negative. But that's my practice. Others would say, and it's true, if I think they have the flu, I might write it out as long as they're under careful observation. And then we should immunize people just like we immunize any adults or asplenic adults, as the case may be, as recommended by the CDC. So what do you do with the kid who's now older, who has pediatric onset stroke? So you had all those nice data about, we can prevent stroke, but then once you go on for that high TCD, you can't stop too, because you're going to have a recurrence. So what Lautenberg recommends is for a patient with a history of stroke as a child, long-term transfusion to maintain hemoglobin S to 30 to 50%. And I only know collectively a group of folks that takes care of probably 20 to 25,000 adults. And I don't mean that flippantly, it's probably 50 or 60. And no, none of us stop transfusion on purpose in the adult world because we don't know. And so I would submit it's a good common practice to sustain transfusion for as long as you can. And there is the equipoise between killing them with their iron and allowing the potential for recurrent stroke. That is ever an ongoing challenge. It's not been studied in adulthood. For adults who decide to stop, consider hydroxyurate. I'm going to talk about hydroxyurate at the very end a little bit more. There are both hemorrhagic and ischemic events, and we don't recommend using TCD, which has never been standardized in adults, to try and guess who's going to have adult onset ischemic stroke, although as that graph quickly went by showed you it does occur in adulthood. What's recommended is urgent exchange transfusion. Why? Because it helps in kids. Go ahead and use antiplatelet agents because maybe they were smoking and got obese and had diabetes by the time they were 55 and had their stroke. And we don't know what the role of chronic transfusion is. I do it. Why? Because we've done it in kids. But I don't think we really know how to manage ischemic stroke that isn't obviously been caused by something else in the adult with sickle cell disease. What about the hemorrhagic stroke or the bleed? It's been recommended to do angiography. If they have an aneurysm, let's coil it. We do that in anyone who doesn't, even that don't have sickle cell disease. And you need the exchange transfusion to do the angiogram, at least in the days gone by when we didn't have MRA. So that got us to the exchange transfusion. And recently, one of the Adult Provider Network providers surveyed what adult providers did for stroke. So almost everyone in the adult world that we can talk to will do an exchange for an adult who has an ischemic stroke, but only about half of us will do an exchange transfusion for a hemorrhagic stroke. And so this gives you at least a feel of what others do, but I can't tell you what the right answer is, and I sure can't tell you what characterizes a high-quality standard because we don't have any data. As in children, if you're going to transfuse, they should have a complete phenotyping. And alloimmunization, in this case, it was a little bit older, not so forceful, can be reduced if you match for CDE and KEL. Chelation is indicated, okay. That would be true. And quantitative tissue liver iron concentration may be needed to guide chelation therapy. And at that time, we talked about the non-invasive squid as well as MRI, not necessarily having to do liver biopsy. So these would be things that the evidence would support, at least indirectly. All right, so what about lungs? And this is an even more controversial in adults than in kids. So it's true per Mark Gladwin's data from now some time ago that a lot of adults have a high TR jet velocity, and a significant portion have a relatively higher, greater than 3 value. And you can see that those people are more likely to be dead in 2 years when you have this finding on echo. But it's all-cause mortality. Okay, it's not necessarily death due to pulmonary hypertension. And if you find a high TRV, then all 30% of those adults should go to right heart cath, because you don't know what it means. 40 to 75% of them will not have pulmonary hypertension despite a very abnormal echo. They'll have high throughput states, and about half of those that do have high pressures actually have evidence of left-sided heart disease. That big old hypertrophied left ventricle will be backing pressure into the lungs, which is managed very differently than true pulmonary hypertension, where you give vasodilator and other therapies directed at the lung circulation. And so screening, or at least testing for symptomatic people, leads ultimately to the catheterization laboratory. And well, there are no data about this, and I even varied from Lautenberg's paper to a very intensive evidence review I did a couple of years ago. There's a lot of case series that say if you have true pulmonary hypertension, you should take true pulmonary hypertension therapy. And that is despite the Walk Fast study, which was closed early because it was going to be futile, and people experienced more pain when they got the drug. So any adult with signs or symptoms of pulmonary hypertension, I'd recommend doing an echo. I'd consider screening all sickle cell anemia adults once, especially as they develop renal disease, because that seems to be the cluster of events or symptoms or persons who are more likely to have pulmonary hypertension, and you have to go to right heart cath. And the bottom line is people say, well, you got to know because you should put them on Hydrea only for this. No one has ever proven that changes anything about their quality of life, their morbidity, or their mortality. So I think it really, in my practice, is a goal to look for pulmonary hypertension or for other changes in the cardiopulmonary circulation that you can fix with the appropriately directed therapy. Now, lots of people in my world, in the adult world, do echoes every year. Is that wrong? I don't think so. Should the insurers stop paying because there's no evidence? I don't think so. But know that it's not based on evidence. It's based on collective experience, arguably back to that legal standard, what our community does around it, but there isn't really evidence to demonstrate that. And then in renal disease in adults, up to 10% go into renal failure, 50% have microalbuminuria, 30% have proteinuria. Captopril improves the proteinuria, but there's no evidence this changes long-term outcomes to take the medications long-term. We borrow from diabetes in adults and say, well, I bet it'll make them better, let's go ahead and do it. I do it. Is it a quality standard? No. Well, the guidelines say you should. Very controversial, even still as we finish to finalize it. More on that when they come out. You can see what you think when they're available. It was recommended that annual renal function by serum creatinine and screening for proteinuria. That's what Lautenberg had to say. They should be treated if you find it, and if you know that they have renal disease, you should be careful about nephrotoxins. EPO works, and it should be given. Dialysis works, and it should be given. We should take care not to drive the hemoglobin too high if they're receiving erythropoietin because of viscosity. We've learned that anyway in the non-sickle cell population, and they should get transplants and dialysis just like everyone else. Other managements that's in the Lautenberg document include the use of oral contraceptives, including those containing estrogen, are not contraindicated in sickle cell disease, to talk about the risks and benefits with individuals. Prophylactic transfusion is recommended for pregnancy. It's one of the 5 old randomized trials in adults. And the recommendations are there. And then there's a lot of other specific, not a lot, there's other areas that are addressed I'm not going to do in the interest of time that talk about preoperative transfusion, both true for kids and adults, and then some specific principles of management, as we call them, for priapism. And they're available in the document. Another one I encourage you to get in lieu of the guidelines coming out. And then we endorse the U.S. Preventive Services Task Force. These people can get breast cancer. I had a lady die of metastatic adenocarcinoma. The woman who went on dialysis for her lupus because no one recognized it for 10 years. You have to remember that there are comorbidities and they need to have holistic, complete management in a primary care medical home, at least, that looks to all the possibilities. So in the last couple of minutes, I want to talk about disease modification. So hydroxyurea, as was already alluded to in detail, was demonstrated to show a 50% reduction in both pain events and acute episodes of acute chest syndrome in adults. The baby hug trial that recently came out actually didn't show a difference in splenic or renal function, at least not statistically significantly. And I think that's a very high bar. I mean, even sickle cell trait people don't concentrate their urine. I think that's asking for a miracle therapy, not just a drug that can improve your disease. And I was bolstered by the comment you heard earlier today that the IQ scores appear to be better. Neurocognitive function appears to be better in those infants that were on hydroxyurea as compared to those who were on placebo. So I'm not completely cynical about chronic organ damage with hydroxyurea, but the big home run, unintended with baby hug, was that they markedly reduced the episodes of acute chest syndrome and pain events, including the hand-foot, in the infants, just like it did in the adults. So we now have evidence about that. However, and this is just to bolster a point about whether or not it fixes chronic organ damage, in the switch study, as you'll recall, this was to switch kids from transfusion who were on to prevent a secondary stroke to hydroxyurea, and they only got partway down the randomization before the study was closed. And it wasn't because the kids in Hydrea had 7 strokes and the ones who stayed on transfusion was 0. Although that scares me, it was still too early for statistics to play out. But it was because it was never going to show that you could unload iron better to counterbalance those stroke risks that might be higher in Hydrea. And so, honestly, it was as much a challenge with the study design as the outcomes. But it still reinforces to me, I'm not sure hydroxyurea actually fixes chronic organ damage. The only way to know is to see what happens to the baby hug cohort when they've had it since before they started to switch and see what happens long term. So recommendations vary, if you will, quality indicators even. Hydroxyurea is indicated patients with hemoglobin SS and S beta 0 with frequent, how often is that? Moderate to severe, a qualitative commentary, or chronic pain should try hydroxyurea. The Wang group suggested that quality indicators hydroxyurea should be recommended for children 5 or older with recurrent painful episodes or ACS, and the recommendation should be documented. How many is recurrent? And I would submit if the panel was sitting today, they'd consider now saying 9 to 12 months old based on baby hug, but I don't know. It's controversial, I think. And as yet, we don't have benefit in other disease states or in chronic organ damage. And then finally, there's a cure, right? That is the stem cell transplant that we heard it mentioned before. It is a cure with certainty for children. Not it's a certain cure, but with certainty it can be a cure in children. The top dark line shows the kids who are alive after transplant. I don't mean that flippantly, although in childhood that you guys think about it differently than I do. They all die on my watch. Right? I mean, hopefully when they're grandparents or great-grandparents, but they all will die. That is a reality in my practice. It's just, can I keep them from dying till they absolutely, there's no way to prevent that. But you can see that most kids alive, 90 to 95% are alive after transplant. Most of those who are alive are disease-free, 85 to 90%. And that there is, events on the bottom, including death and graft-versus-host disease. Not quite this way, but you certainly can give them a cord blood transplant. You can get peripheral. You can get bone marrow. They can be related. They can be unrelated. We can't do the minis, but we can do the reduced intensity. But in adults, I think it's still considered experimental. A plug for an ongoing national effort that we have that's looking at coalescing data around a single transplant protocol in adults, which is ongoing. For the kids, the quality indicators were families of children with sickle cell anemia younger than 16 with history of stroke, recurrent chest syndrome, painful episodes should be offered the option of transplant, and write it down. That's demonstrating, they would say, that you have a high quality practice, that you have discussed with the child who has any of these criteria the option of having a transplantation, and that children with sickle cell anemia younger than 16 without evidence of end organ damage should be counseled that this is a cure. Information, they're going to come to you, at least my adult patients do, and ask about it. But this is considered such an important potential intervention that the folks who devise quality markers of a good, solid practice in sickle cell suggest that you have documented that you have talked with family to kids under the age of 16, because that's often the cutoff for the transplant protocols. At least you've talked about it, that it's a potential cure. Whether or not they choose to take it, that's completely an individual and family choice. And so in summary, I'd tell you that quality indicators are well developed in pediatrics. Whether you agree with all of them or not, it's open for discussion along the way. But we badly need that same process in adults, at least to get experts to agree on a consensus, if not based on evidence. There are guidelines coming, let me say. It's hampered by a lack of high-quality evidence, although experience is evidence, and that's built a lot of this 250-page document that's about to be forthcoming from NHLBI. And then I would say standard of care as a term is still a work in progress with sickle cell. And I think as practitioners who care for individuals and their families living with sickle cell disease, I had recently had the chance to see the cherry blossoms in Washington, D.C., and Thomas Jefferson once said, in matters of style, swim with the current. But in matters of principles, prophylactic penicillin perhaps, TCD arguably with the evidence, stand like a rock. There are some very basic things that I think everyone ought to apply, certainly in pediatrics, and arguably some principles in adulthood, that we can stand like a rock and not just have to do it based on style, but at least we can bring our collective styles together to bring high quality care. And with that, I'm going to go ahead and stop and take questions, or we can wait if you want till the next speaker's done. It's up to you.
We'll take a few questions.
Okay, thanks. There are any. I made it through most of the postprandial. Go ahead.
Thanks, Dr. Hassell. Regarding hydroxyurea,
Yes.
indicated in SS in S-beta thal null,
Uh-huh.
not in SC and beta thal plus.
Right.
Why not?
So, firstly, they went over data. So that's why, like, a quality indicator doesn't rise to, like, with Wang's group, and why, in general, when we talk about it in guidelines, there aren't any evidence. The theoretical reason behind that is the gene switching that takes place is more likely to take place in a gene system for a couple of different reasons, but including a very high reticulocytosis and the degree of anemia that is true in sickle cell anemia and S-beta 0 thalassemia. That is to say, they're more anemic, they're reticking all the time. You got 20 or 30% of cells going into that process that are more likely to be affectable by a drug that creates the gene switching. And in fact, the only study that's been attempted in SC disease also sought to change the red cell hydration in hemoglobin SC disease. So there was an arm that was hydria alone, but they also sought to change the physiology of the pathophysiology of the red cell as well. So there's no evidence that you can effectively drive fetal hemoglobin in hemoglobin SC disease or hemoglobin S beta plus cell. Now, can you? I bet anecdotally people have succeeded. We heard earlier today that driving fetal hemoglobin may not be the only point. The size of the red blood cells arguably will get big. Maybe that's good. There's fewer hemoglobin molecules banging around. You lower the white blood cell count. Since this is also an inflammatory disease, maybe that's good. But there's no evidence that it makes the same impact that we associate with benefit in the diseases in which it's been studied. And there's a theoretical reason to think there might be a different effect. So that's why. Now, again, this is, maybe it's worked for some folks. And maybe you've seen high fetal hemoglobin. I would never say that's not true. But as for groups as a whole, gosh, if we could just get the people with SS who needed to be on it, we'd take a huge, step, I think, for the population as a whole. Okay. Did I see a hand? Yes, sir.
I would add to Hassell and Eric, is in the SC patients, we never see them have fetal hemoglobin
Right.
after infancy. But I think there was a paper that just came out that showed somebody using it in SC patients that did have some benefit, but probably not as much.
Yeah, and it's all about, we need to study stuff. And that's easy to say, but it's expensive and we need people to be willing to participate, and life is increasingly complicated with different therapies and different options. So it's not so easy to get data, but that would be ideal. And I think there's theoretical reasons why it's potentially not going to work.
And on some of that, we have seen people come to us on transfusions and still on hydria.
Yeah.
And hydria really can't do anything while you're on transfusions.
Yeah,
You can knock it down temporarily when somebody gets transfused for other reasons, I think.
right. So I think, again, because you're looking at changing gene in a highly turning population that's turning over, at least initially, some people have done that in desperation, really, on behalf of the patient, because, the transfusions aren't working, and let's make the red cells they do make have high fetal hemoglobin. I haven't seen data as to whether or not you actually see higher fetal hemoglobin in their cells, because you can't tell. You'd have to do F cell preparations in a research lab. You couldn't really, because blood bank blood, it all pools together when you do the electrophoresis.
Yeah, I think when we decrease their hematopoietic drive,
Right.
hemoglobin just goes down.
Yeah, no,
Out of curiosity, some people who've been on hydria had a stroke. We've kept them on it while we started
Uh-huh.
transfusions, and the fetal hemoglobin just drops
Yeah. So I think it is about, so remember the first slide, if you don't have evidence, let's look at principles, and that would be kind of the principle behind it.
My other question
Yes,
is
sir.
about the TRD
Yeah.
death loss.
Uh-huh.
If we find a lot of them in adolescence,
Uh-huh.
does it go away, or does it persist into adulthood, and then when you find it still in adulthood, there's a high risk?
We have no idea. Absolutely none. It's because it's cross-sectional, right? So we actually have no idea. I would postulate that it doesn't go away, right? I would think of that as, proteinuria may come and go, but, may mark an inexorable process, but we actually don't know.
So then the conclusion would be is that if it persists and doesn't change,
Uh-huh.
if you find it then in adulthood and it's a risk factor, why doesn't changing it in adolescence or trying
Right.
to change it? Or do we have anything effective to change it?
Well, we don't know how to fix it because we don't know what it means, right? I mean, if you have a high pulmonary pressure, we know how to intervene. Whether that changes is a different issue, right? But I think in kids, it's most always a high flow state, which may be intrinsically bad, but the fix might be something very different than we might think about. And maybe even Hydrea doesn't offer that fix. Or even transplant, although arguably transplant at least eradicates the disease for the survivors who do well. And, that ought to be a no-brainer kind of thing, and follow-up and often is for the transplant studies. I see a hook here, so thank you all.
Thank you, Dr. Hassell. Okay, so up next we have Dr. Michael D. Bell. He is the attending emergency physician at the Children's Hospital in Oakland. Dr. Bell has strong ties to the Oakland medical community and has served as chairman of the board of directors at the West Berkeley Health Center and medical director of the Bay Area Sickle Cell Camp. He was awarded the Citation of Merit by the Bay Area Sickle Cell Council in 2005. Dr. Bell's clinical research interests includes treating vaso-occlusive pain crisis in the emergency department and is involved in a national HRSA-supported acute care ED management group on sickle cell. He was also a speaker at the 40th Convention of Sickle Cell Disease Association of America on improving management of pain related to sickle cell disease in the emergency department. Welcome, Dr. Bell.
I apologize for the spelling mistake. I actually was asked to talk about emergency room treatment of emergencies in sickle cell, but I think we actually have talked about most of them, and I'm going to mainly talk about what is my forte in the emergency department, acute treatment of sickle cell crisis. Just to start out with that, as we have, several speakers have noted that there's been a great decrease in deaths of sickle cell, but it's important to realize that still, only 6% of children have any symptoms by 6 months of age. We had the lady here earlier who said, I have a baby, hasn't had any problems. But, we don't expect many problems under 6 months of age. Only by 1 year of age, only 32% of patients have had any manifestations of sickle cell. And 2 years, that changes to 61%. So, a lot of people don't have any manifestations for a while. And we've talked about the mortality, so I'm going to just skip this. So I'm going to talk about vaso-occlusive crisis and how it's treated in the emergency room. I have the great Elliot Kaczynski at my hospital, who is one of the fathers of sickle cell research. And we have this argument all the time that sickle cell should no longer be an emergency room disease. And that's probably theoretically true, but in practicality, it is not We have 732 people in the Oakland Comprehensive Sickle Cell Department. And we have one of the few places where we take care of the pediatric and the adult people. The adult people are admitted to adult hospital, but they receive their outpatient care at Children's Hospital. So out of 732, about half are under 18. So out of that, we see 479 sickle cell visits a year. And that encompasses 115 patients. So obviously there's a subset of patients that come to the emergency room more than the other patients. 264% of the visits are for painful crisis and others are for fever or whatever. 69% of the patients that come to us are admitted to the hospital, which is a very high number. So what we want to talk about is the emergency room experience, what should happen, what's new, what's going to happen. You know, it's important with the acute treatment of sickle cell, we have to be very careful not to overhydrate. We never bolus patients unless they are severely dehydrated. We usually never give more than 1.5 times maintenance of fluid. The studies have shown there's no beneficial effect to oxygen if they're not hypoxic. When I started, we gave everybody oxygen for everything. We no longer do that. But I really want to talk about what's new and what we're doing at several centers around the country. NICHQ has funded a quality improvement study, and it's being done at several children's and adult hospitals to change the perception and the care of sickle cell patients in the emergency department. And let me just tell you, when I first heard about this, I said, we're in Oakland, we're in the place where Dr. Fitzgerald is, we're in the place where the Black Panthers started sickle cell screening in the 60s. And, so we're in a community that has a pretty high IQ on sickle cell, I thought. And that's not necessarily true either. But it really goes to show, and I always say this, you never know what you're really doing till you pull the data. I thought that we were doing very good in treating patients with sickle cell. When we looked at it, and we're a premier sickle cell comprehensive sickle cell center. When we looked at it, it took 90 minutes for the average person to come to triage and receive their first narcotic for a sickle cell crisis. The national benchmark has been set at 30 minutes. So we were 3 times what the national benchmark is. And this is the same thing, every hospital that looked at it found the same thing. So this new outcome study was to look at, to try to have interventions that would decrease the amount of time that people were waiting to get their first narcotic. Also, we found that every doctor was giving a different dose of opiate for the crisis. Some were giving tiny doses, some were giving big doses, some were giving in-between doses. So also our goal was to standardize that everybody was given what was considered a sufficient dose of narcotics. And the whole idea is if you break the cycle, that hopefully that, with sufficient amount of narcotics that you can help break the crisis. Now that's another controversial subject that I won't go into, but that's the theory behind it. Certainly, patients appreciate you treating their pain crisis more aggressively. So under this new protocol, and for it to work correctly, what it entitles, and again, this is happening in the pediatric and the adult facilities, is that when you come into our emergency room and you're a sickle cell patient and you're in crisis, right now you should be offered intranasal fentanyl as your first line drug within 5 minutes of you getting into the emergency room. You should receive a second dose of intranasal fentanyl 5 minutes later. So that's the big change that we made in our protocol, that we added intranasal fentanyl. Now, intranasal fentanyl, for you people who haven't used it, is something that we've been using in pediatric emergency rooms for a couple of years. When somebody breaks their bone or comes in with a broken leg or something, until we get the IV in and we want to give them some pain relief, we use intranasal fentanyl. It's just squirted up their nose with a special atomizer that aerosolizes it, and they get instant relief from that, and until you can start the IV, if you need to do a reduction and so forth and so on. So it was a natural thing to give immediate care to children who come in with vaso-occlusive crisis, to give them the intranasal fentanyl. Now, granted, some of the older kids don't want things squared up their nose and have some problems with it, but it does offer significant relief. The other thing is that we standardized the amount of morphine that the patient gets. We give what is considered very large doses. Everybody gets 0.1 to 0.15 milligrams per kilo of morphine. That's non-negotiable unless for some reason their hematologist has put a note on their chart that they can't get that, or sometimes they put on their chart they need more than that. But if you don't have, your hematologist hasn't said different, everybody gets somewhere between 0.1 and 0.15 milligrams of narcotic. Our goal is to start the IV within 15 minutes of you presenting to the emergency room, and that you should have your first dose of IV narcotics by 30 minutes. So at 30 minutes, you should have had 2 doses of intranasal fentanyl and 1 dose of IV narcotics. Now, the important thing to make this really work the way it should work, this should be a protocol that is nurse-driven, not doctor-driven. Because we all know in busy emergency rooms, it's hard to get a doctor to evaluate a patient between each dose of medicine. And so what we have in this study have done is to allow the nurse to assess the pain, and for the older kids, it's asking them, what their pain score is. Now, there's a lot of controversy, and we're going to certainly look at, the education around children telling us what their pain score is. Because like the previous speaker says, a lot of people, it's always 10, or it's always 9. It's always a certain number. But right now, we have to say, if they say it, believe it. So if they say the pain score is 9, if their pain score is 5 or greater, they get their morphine. And 15 minutes later, they get reassessed, asked what their pain score. And for the younger kids, there's a scale that has to do with faces and the normal thing, or whether they're crying, So if they're by either scale, if their pain score is 5 or greater, they get a second dose of morphine in 15 minutes. So theoretically, by an hour, they should have gotten 2 doses of intranasal fentanyl and at least 2 doses of IV morphine. After the second or third dose, and they can get reassessed and they can get up to 3 doses in the emergency room. After that, they have to either be admitted or they have to have a discharge plan. So after the second dose, we contact the hematologist because we confer with the hematologist on every patient that comes to the emergency room for a hemoglobin-related illness. We contact the hematologist and we decide on a plan. For the older kids, they usually pretty much decide whether they feel they can go home or not. And the younger kids, the parents kind of make that decision for them. Now, granted, we have a lot of working adults, young adults, and older teenagers who are very much into school who say, you know, I just got to go home no matter how much pain I'm in, and, you know, and they go home. And then we have the patients that never go home. You know, whenever they come in, you know they're going to give, oh, I'm 10 out of 10, I need to stay. And that's a problem. But I think what we have done, we have changed our time to first drug to about 10 minutes with intranasal fentanyl. The time to first narcotic to 40 minutes. We haven't gotten to the national benchmark of 30 minutes, but we went from 90 minutes to 40 minutes. And in my hospital, to have that kind of intervention and change is remarkable. And it even was sustained in our busy periods. You know, in pediatrics in the wintertime, you know, we're just like adult hospitals. The average weight in my hospital in midwinter can be 3 to 5 hours. So the fact that we were able to sustain this even at our peak times was amazing to me. Now, we also do a patient satisfaction survey that they usually get within 72 hours. Somebody will call them and ask them how do the parents and the patient perceive the care was. And of course, they love this new protocol. I always, whether it's my patient or not, I always spend time talking to the parents and the patient to let them know what the protocol is and know what they should expect. Because I think that's the important part. Because if they don't know what they should expect, they can't voice any problem with the fact that we didn't meet our own standards. So it's important for the patient to know what the protocol is. Now, there's some thought that that doing this, giving quick, large doses of narcotics very rapidly, would decrease the amount of patients that needed to be admitted. We have not been able to show that. Now, I know the Boston group has shown some slight decrease in their admission rates. We have not been able to show that. And the good thing is this is a multi-center operation, and so we will get everybody's data and publish it, you know, and it means much more than any one center. But certainly, I think the quality of care has increased in our institution by doing this. There is some problems we have. I spend most of my time, you know, outside when I'm doing this because I review every chart that is an outlier. If it took more than 40 minutes for you to get your first dose of narcotics, I review that. And I go talk to the providers involved, both the nurse and the doctor, and try to get up a reason why your patient was an outlier. And a lot of times, it's the doctors that are the clog in the wheel. Because we still have our own prejudices and we still have our own biases. And often doctors will say, I went in the room and the patient was asleep, so obviously they didn't need any more medicine. And, you know, I try to tell them that, you know, that some patients, you know, use sleep as a way to control their pain. they try to block out everything. So that's the only. So if they wake up or you wake them up and they still say they're 9 or 10, we have to believe that, and we have to keep doing it. So we've just gotten to the point where, because they get tired of seeing me coming, because when they see me coming, they know we're going to talk about a sickle cell patient that was an outlier. And so we've just gotten to the point, and we've been doing this since August, that I really have very few people I need to talk to because of the biases. We are a program that we have residents from several different programs. We have adult emergency medicines from residents from 2 programs. We have family practice residents. We have our own pediatric residents. We have pediatric residents from another hospital. So we're a real mixed bag in terms of residents. So we didn't want this to be anything to do with the residents. All the residents do have to do is follow the sheet. Everything's on the sheet. What dose you need to give, how often you need to do it, all you need to do is follow the sheet. So there's really no thinking involved. Now, another problem, in fact, when I go back, I have to go talk to the hematology department because they're complaining that the patients are over-sedated when they get to the floor. And I'm like, well, you can't have it all, everything. They're not hypoxic. We can put, everybody, we can put CO2 monitors on everybody if that's what you want, us to do. But we've never been able to show that, the fact that they're sleepy, so what? They're going to have a PCA when they get upstairs anyhow, and they're going to give their own medicine. So I really don't want to hear that. And it really affects our staff when they hear that, we think we're doing such a good job, and then you give us this stuff, but, why did so-and-so give this much medicine when that's the protocol that you approve? Believe me, you can never do nothing in my hospital with a sickle cell patient unless hematology has approved it. So it actually has worked well, and part of our part of it is that we are supposed to now transition this to the local adult hospitals. Now that's going to be the hard part, and for 2 reasons. One, the adult people have already published their data, and they have shown that, first of all, they couldn't meet any of the guidelines, any of the benchmarks. And I think that's multifactorial. So it didn't work for them. And what was really interesting in the adults population, some places even offered to give IM or sub-Q opiates while patients waited in the waiting area. But they couldn't get any of the nurses to actually do it. Everybody was worried about, if there's a complication, I'm in trouble. Even though we never see a complication from any of this. And people do it in their office all the time and don't have a complication. Also, the amount of true emergencies are different in an adult emergency room. If you have 5 people with a heart attack, and you have a sickle cell patient who comes in, that sickle cell patient, I don't care how much you talk to people, is not going to get the same kind of urgency as the person with the heart attack. So the acuity is different in the adult facilities too. So, and you do have in the adult facilities too, you do have even a stronger bias problem. And maybe for good reasons. I don't think we really see drug seeking in the pediatric population. And I think maybe, to a certain degree, that there's more of that in the adult population. Because there's obviously more drug-dependent people in the adult population, period. I'm just, guessing here. But certainly, we don't worry about drug seeking in the pediatric ER. Where in the adult ER, that's a major, when you talk to the adult emergency medicine people, that's a major concern, whether people are drug seeking or whether they really have pain. You know, but, you know, as I tell my residents, you know, who go through this, and like I said, you know, half of them are adult emergency medicine residents, at least here, if they say it, you got to believe it. You know, we're not their, you know, we're not their hematologists, we're not their primary care physician. You know, that's their job to figure out. Now, if they call me and they say, or they put on their bulletin board that, you know, this is a drug-seeking person, he signed a contract. We have some patients that are under contracts, but that they can't only get certain things because either okay.
Sorry.
We have certain people who are under contract, you know, with their hematologists, that they can't get certain drugs or they can't get narcotics because either narcotics haven't worked for them or that they, you know, have developed, you know, some drug-seeking behavior. But that's not something as emergency physicians that I don't know the individual person that I should be involved in. That's something that somebody who follows that patient on an ongoing basis should determine. Now, there's a few things on the horizon that we're looking at. One of my fellows approached me the other day about looking at low-dose ketamine in these kids in acute pain crisis. Now, in the adult world, there's a lot of excitement about people with chronic diseases giving them a low dose of ketamine. And the theory is the dissociative properties of ketamine help break the pain cycle. You know, I know there's one study going on with people with chronic migraines doing that. And that's an exciting thing because I don't think, and I was talking to the guy earlier that is working on the drugs that increase circulation of people in sickle cell. I don't think there will ever be a perfect opiate to treat pain crisis. You know, you can make an opiate as strong as you want to, and even if it doesn't have as much abuse potential, it's still opiate and it's not treating the underlying cause of the pain crisis. So until we can find things that actually treat the underlying pain crisis, this is the best we have. You know, so basically we have hydration in the emergency room and we have pain treatment. So, to say, the whole purpose of this is when people looked at thousands of charts from hundreds of different institutions, they saw the same thing, that sickle cell patients were inadequately treated with pain medicines and weren't given them in a timely manner, and that's why this all came about. So that has changed in a lot of centers, and when the NIH comes out with its new guidelines, supposedly they're going to have emergency room guidelines too, and we hope they at least publish some of these things as benchmarks for people that, so that at least they will pull their own data, see how well they're doing, and see what interventions they can do to better bring them closer to the benchmarks.
I make one comment on the drugs.
Mm-hmm.
What we've seen is, I've never really seen a kid with that, or at least less than a teenager.
Mm-hmm.
We have seen parents or family members who are having them come in and use their prescriptions for other purposes. And sometimes those are the people who are more than willing to come. Sometimes they aren't willing to come to the ER, they just want to get stuff over the phone. Or if they come to the ER, they're more than willing to go home with a prescription rather than be admitted.
Yeah, and I can tell you my personal practice is I only give people 3 or 4 days of pain medicine. Then I think it's up to their primary care or their hematologist to do from there. So I don't give people large prescriptions for narcotics. And I use that as a rule of thumb for all my patients, whether they're cancer, whether they're broken leg or whatever, because one thing I think that we need to encourage people to go to their primary care providers. And we do see that not only in sickle cell, but I see that in a lot of different things that, that I have questioned whether the parents are taking the medicine or whether the kids are. So, we don't want to become the refill, or if there's some reason they need a bigger thing, then I call the provider, and it's only if the provider tells me that, to give them a bigger prescription, will I do it. But we do see parents that are drug seeking. Any other questions along that line? I can honestly say, though, our patient and parent satisfaction has increased through the roof since we have started this. And not only I think that is because we give them better care or quicker care, because we can't really demonstrate that this care has made a big difference. The next part of it we're going to look at, and we have been looking at, is there any decrease in the amount of time these patients are admitted to the hospital? And also what I want to look at, does it make a difference whether the patients really had adequate PO trials of narcotics before they came in, how long they were having crisis before they came in? Does that make a difference? Because we are very much encouraged all our patients are basically, all the pediatric patients are followed by a hematologist. And there's a hematology fellow that they can call 24 hours a day. They can get refills that way. Obviously they keep a record of how many refills they got, which I don't have. And so we encouraged, our patients, education part of this has to be an important part too. Did you call the hematology fellow when you first started having problems? Did you try this? How many doses of pain medicine did you have before you came in? And we haven't looked at that data or really collected that data yet to see if there's a subset that this really would decrease the amount of admissions necessary, or is it, was it make no difference for any of them? Any other questions? I have a whole slide of all the things that we've already talked about, acute chest and sequestration, and I don't think we need to go through all of that again. Mm-hmm.
The ones that they know is not, misusing their medicine or whatever, they need to get some kind of plan together to get them in faster. I have been in crisis and went to the emergency room. I had to wait 12 hours.
And that's why this national improvement thing came about, because we know that's a problem. Now, you're talking about for care for yourself, right? For adults. We have talked about this in a lot. Adult care, I know that I was talking to the people from a lot of different pediatric hospitals, and we were talking about this earlier. Adult care is very fragmented in a lot of different places. In Oakland, we do not have a university program in Oakland. So we have the county hospital, which doesn't take care of any sickle cell patients. basically, we had a program at one of the private hospitals that admitted the adult sickle cell patients, and they weren't getting adequate care, and that's why our hematology department, our pediatric hematology department, took over the adult care. They hired adult physicians to admit the patients to the adult hospital, but and that's why we're trying to transition this approach to the adult emergency rooms in our area too. I think if there ever comes out to be national benchmarks that actually come out from the NIH, that every emergency department will have to at least look at, their statistics and try to implement things to make it better for the adult population. But, I can tell you, having a parent that was sick and having to spend a lot of time, and I do work in some adult emergency rooms too, even though I'm a pediatric emergency medicine specialist, that, adult care is totally different. And that, unfortunately, if you're in pain crisis, you need to keep going to the triage nurse and tell them that you're in pain, that you haven't, been helped. And it's hard. I saw a lot of patients with sickle cell sitting in the waiting area for hours and hours in pain crisis. That has to change. But it's only going to change, I think, when there's really some national benchmarks that apply to all emergency rooms, whether they're pediatric or adult.
Yeah, because I know me, because I'm the kind of person where now that I know that it takes that long to get seen, and they'll put anybody before you. I'll go suffer my crisis sometimes for 4 days, 3 or 4 days, and then I'll go to the clinic and they'll treat me at the clinic, and then they'll put me in the hospital, because that way I can go ahead in and get treated, and then I can come home, because I'm not going to stay in the hospital or, do all that. And so I'd rather just go to the clinic.
Well, when you have options, that's always the best option. Unless you truly have an emergency, and that's the problem with emergency rooms. Let's be quite honest. Probably 80% of what we see in emergency rooms don't belong in emergency rooms. So we're clogged up with people that really shouldn't be there. And if people went to their primary care providers and were directly admitted to the hospital when they know that they need to be admitted, that would, that's probably the best way to do it. But you only can do that during the daytime. You only can do that if your primary provider has admitting privileges to the hospital that you're going to. So there's some limitations with that too. But, I think the real answer is the crises with emergency room, not just with sickle cell, but with everything. Most, there's been a lot of press recently about that, urban emergency rooms are just overcrowded, overutilized, and understaffed. And that often in adult emergency rooms, 8-hour wait is not unusual. And like I said, even in my hospital, in the wintertime, a 3 to 5 hour wait is not unusual too. Hopefully, the 3 to 5 hour wait are people that shouldn't have been there in the first place, but you don't know that for sure until you see them. We depend on triage categories. And one of the things that came out of this committee is that we asked the adult facilities to give sickle cell a higher triage category, because you're not seen in the emergency room just by who came first. That can't work in an emergency room. You have to see the sickest patients first. So you're assigned a triage category, and then you're timed by where you are in that particular triage category. So if you're assigned the highest triage category, you're pretty much seeing right away. The next highest you know, that if you came in, you're the third person in that category, then you'll be the third person seen. So it all depends on where they put you in the triage categories. A lot of adult emergency rooms do not put people in pain crisis, you know, in the same triage categories that we do in pediatrics. And that's another thing that we're trying to change. But like I said, until there's national guidelines, you know, I don't think there's going to be a whole lot of change.
Dr. Bell, we currently have developed a sickle cell advisory committee for the state, and I also work with the region for genetics collaborative.
Mm-hmm.
And during working with the genetics collaborative, we worked with Dr. Paula Tanabe and some other health professionals in developing the ED emergency room triage assessment scan thing. And I wanted to know, what we wanted to do is we wanted to start implementing it here to our ER so that when the patients do go to hospitals other than, say, IU or Riley, which Dr. Heine is, or out at St. Vincent's where we are, we wanted to maybe start there. What would be your maybe recommendation on, you know, where we get started with maybe introducing it and maybe how we could get the emergency room departments to kind of buy into it and possibly start using that to better triage the patients when they come?
Well, the first thing I would recommend, first of all, you have to show them they have a problem. So the first thing I would recommend is to ask them to pull their own statistics and look at, you know, maybe just 2 months of, you know, the last 2 months of all the sickle cell, the people that were coded as vaso-occlusive crisis, and just pull the statistics on the last 2 months and see what the average wait time was from, you know, everybody has these times. The time that you went to triage to the time that you were seen to the time till you got your first narcotic. So I think when you demonstrate them and you show them what the benchmarks are supposed to be, then I think that gives you a conversation about how we can better improve care to get to those benchmarks. Then I could say, then you can talk about what triage category do you assign patients in pain crisis, and, you know, and other ways that institution can decrease the time for, you know, often, you know, and I've talked to several adult people at the meeting in Baltimore, often having a conversation with the administration and the department about these things, and the local hematologists that admit to those things, to those hospitals, can, you know, if you all get together, you can cause some change. You know, you just have to have, you know, I think that statistics is always better when you have statistics, and you can talk from you're not just giving people theoretical things. In your hospital, you know, you look at your own statistics, the average person waits 2 or 3 hours to get their first narcotic for pain crisis. That's unacceptable. And if you show them what the national benchmark is, that's truly unacceptable. So I think that's the first way to start the conversation. And then, you know, the conversation from that is, it's unacceptable, but how do we go about changing things? And there could be a lot of ways. One way is directly admitting a lot of your pain crisis, especially, you know, I know a lot of places that people will go see their primary care doctor. The doctor will say that they need to be admitted, but he still sends them to the emergency room. If those people can be directly admitted, then that gives you, you know, takes you all out of that loop for 12 hours. Be directly admitted. And maybe that's something that you need to talk to your hematologist and your primary care providers. You know, that's what one of the things that your organization can do to keep people out of the emergency room that they know need to be admitted.
And I think that's the doctors that are in here, the workers that are contest to that. We do, I believe, when we have patients, if they come in and see us, and we send them directly to the hospital so they can bypass.
Mm-hmm.
And even if the baby has a fever and we're able to get them in, you know, we'll have the parents bring them into our clinic, and, you know, we'll give them their antibiotic and see if they have an infection, and it kind of helps bypass the ER. But we, when we're looking at the other regions of the state or those, the hospitals that people might go to where there isn't a hematologist, and I think that's where the emergency room.
Well, I might disagree a little bit in pediatrics. Being an emergency physician, I think if a sickle cell baby has a fever, he should come to the emergency room. I think, he needs blood cultures, he needs IV antibiotics, and pretty much all the young kids 100% get admitted. So, I think that these kind of things you have to work out with your local hematologist too. You don't want to start things that might be against the standard of care in your community. So I think it's great having something like the Martin Center because you're in a great position to do these kind of things. You can go to your pediatric hematologist and say, what is acceptable for a baby, under a certain age, should they all go to the emergency room? Can we handle this? Or to your adult hematologist, it's a beautiful thing to have a group like that it really can negotiate for the patients. But, I think that you have to first do no harm. You need to have a standard of care and make sure you're following that standard of care. And I know in at least where I work that we would never encourage young kids with fevers to go anywhere but to the hospital.
We do see our kids in the hematology clinic during the daytime when they call in because our nurses are used to giving antibiotics quickly for oncology patients who are febrile and neutropenic, so we can get antibiotics in quicker than the ER probably.
Oh yeah, and we do that too. I'm saying to an outside clinic.
I think the pediatricians and probably the internists maybe aren't very well equipped to deal with a sick patient in their office. So
Yeah.
Usually we tell our families that if you get a fever, don't call your pediatrician, call us, because we're going to do things differently. We're not just going to say, oh, you have an ear infection and put you on some amoxicillin, which is what sometimes the pediatricians will do, because they can't afford to take time or do parenteral antibiotics in their office. If they see them in their office, they should send them to the ER, but because they're not going to be able to treat them appropriately there with their schedule. So.
And that's my whole point. If certainly, when patients go to the hematology clinic, they're treated appropriately and they're directly admitted. They don't come to the ER. Unless, for some reason there's no bed available or something, they go directly to the floor, and that's fine. But I'm talking about going to your doctor's office or going, you have to know when you can go to your primary care physician and when you should come to the emergency room. There is appropriate uses of the emergency room. And I consider that, if you have a young child with a fever and has sickle cell, then the appropriate thing is they should be in a hospital-based practice, whether that's the hematology office or whether that's the emergency room. Because we consider, it's just like the kid with neutropenia with fever. We consider that, we don't have that many true emergencies in pediatrics besides trauma. We consider that one of our true emergencies. And we have a standard of care just like, we have in this. A neutropenic patient with fever has to have his antibiotics within 30 minutes. That's the standard of care. And we review everybody that comes into our place that is neutropenic and got fever and didn't have antibiotics. Somebody's going to get talked to by somebody above my grade pay, my grade. Any other questions?
One would think if you can get antibiotics within 30 minutes, you should be able to get a dose of narcotics within 30 minutes.
Yes, you should. But again, it's the triage category. Neutropenic patients are like right away. Everybody stops. If you're seeing another patient, you have to stop. Somebody has to go and do that right away. That has never been the mindset for pain crisis.
Just like the MI patient.
Yes. Yeah. So, emergency rooms have to work on that, in that way. But, sometimes you have to realign your priorities too. There's no reason why you know, a sickle cell patient in pain crisis can't get his blood drawn, because they all get blood drawn too. You know, it's not just, you know, narcotics, but they could be in the hallway and get their stuff. They don't have to have a room for them. You know, there's ways of getting around, you know, not giving them anything.
On your protocol here, can that be nurse-driven for the repeat doses, or does your MD have to come around?
No, the repeat dose. In my hospital, we haven't been able to work it out. But the way it's supposed to be is once the doctor signs off on this, it's supposed to be completely nurse-driven from there. We have not been able to work that out in my hospital. Basically, in my hospital, the nurse just has to come find the doctor and say, sign here, basically. But, you know, we're going to Epic in the next 6 months, and hopefully it'll just be an order set, and that won't happen. And in Boston and some of the other places, you know, that's the way it is. You know, when the patient comes in, an order set comes up in Epic, and they go right through it, and the nurse doesn't have to see the doctor in between.
Or could some of the delays be if people get busy seeing somebody else in between that they forget when their 10 minutes are up? Or
certainly. Or if a trauma comes in, we're a trauma center. You know, sometimes, you know, we get, you know, we're in Oakland, we get pediatric gunshots, and, you know, and sometimes there are multiple traumas, and we have to pull people from other things. So there's some legitimate reasons that it happened. But, you know, the fact that it was 90 minutes before we started this tells us there was a lot of illegitimate reasons it happens too. You know, when you think of the average was 90 minutes, then there were some people that were 2 or 3 hours. You know. Now, some of those because they weren't diagnosed as pain crisis. You know, we have kids that come in with sickle cell who people, I just had one the other day, who came in with vaginal cramps. And, you know, you know, so she did not necessarily go on the pain protocol. But it turned out to actually be a sickle cell crisis. Besides, she had PID, but, you know, so it's easy to focus on another thing and not realize that this patient still has sickle cell. Just because they have pain because of another thing doesn't mean it's not sickle cell at all. It's not sickle cell too. So, you know, we have legitimate reasons why it's prolonged sometimes. You know, we just added, you know, also fever to the same protocol because we have kids that come in with pain and fever. So we're concerned about acute chest. So not only do they have to, again, not only do they have to have their blood drawn and their narcotic in 30 minutes, they have to have their ceftriaxone also. So they get, you know, in the old days, they get their x-ray. If the x-ray was, somebody had to look at the x-ray. If the x-ray was positive, then they would get some ceftriaxone. Now, if you have a fever right away, you're getting ceftriaxone. It's part of the protocol. So again, you know, once the doctor signs out, that's all done. All the doses are right there on the sheet. Nobody has to think about anything. Mm-hmm.
Do you determine if females of childbearing age are pregnant?
There has been some controversy at our hospital. No, we do not. And the reason it came up is because out of the, I think, 10 pediatric hospitals that are doing this, about half use ketorolac and half don't. Ketorolac's been associated with papillary necrosis, and once you've seen a case, it seems like those hospitals never do it again. We did the initial study on ketorolac in the emergency room at our hospital, and we use ketorolac on all our patients. Some hospitals only use it on their patients after if they're going to get admitted, and some hospitals, like I know Pittsburgh, they've had a couple of cases of papillary necrosis, and they don't use it under any circumstances. There is some thought that ketorolac, you know, can have some effect if you're pregnant. So it came up, we researched it. The class of drug that ketorolac was in terms of pregnancy didn't mandate that we do pregnancy tests. So we do not do pregnancy tests on our girls just because they have pain crisis. Now, we do a pregnancy test pretty much in pediatrics, anybody that has pain below the nipple line, period. So if you have abdominal pain, you will get a pregnancy test in my emergency room, regardless of whether you have sickle cell or not. And for one of the main reasons we don't want you if you're pregnant, because we don't have OB services at our hospital. Any other questions?
What do you do for priapism?
Well, we do the standard things. We give you pain medicine. We had a patient that had chronic priapism, and he was in every week, and we actually started doing exchanges of his corpus cavernosa and injecting different things in that, and that was a new thing for me. I had never done that, but he came in every week, so I got pretty used to doing it. There are some drugs that you use for priapism that we used. We try to hydrate them as any other patient. If they have priapism more than 4 or 5 hours, we call our local urologist. And usually we ask them to do the exchange. But, we have had at least 2 patients where the urologist has thought the priapism wasn't totally physiological. We had one patient that self-stimulated chronically. And, but he would have priapism for 4 or 5 hours. And one time, just to convince myself, I gave him ketamine to see if his priapism would go away when he couldn't self-stimulate himself, and it did. So we stopped doing exchanges on him, and but it's a real problem, and it certainly if untreated and it's prolonged can have some permanent effects. I don't know if you have any magic.
Yeah, we don't have any magic, and I remember I do adult care, but I've reviewed all this in different contexts, even for children. So there's no evidence that one needs to approach the sickle cell gentleman with priapism or young man differently than others, and there's a very, actually fairly well-established literature about hydration and pain medicines and oxygenation, even if you don't have sickle cell, because it's about enhancing return from that organ so that it can detumesce or soften. And then the urologic literature varies, I think. Some do even oral agents that change the vasoreactivity, and then some do the phenylephrine injections as this kind of standard next approach, and then a drainage, or as you characterize it, an exchange. Rarely do things like whitten-shurney procedures need to take place. I have a couple of young men with stuttering priapism or chronic episodes, including a person in the hospital right now, and it's problematic. But acutely, it's managed a lot like another individual's priapism. And it seems in urology there's a lot of the conservative stuff and then injection of certain agents and or drainage of the area. As you may know, transfusion is somewhat controversial in sickle cell disease. There was a case series some time ago for what was called the Aspen syndrome, which is where young boys really received an exchange transfusion for sickle cell and within 10 days experienced acute neurologic events. And you'd say, well, fluke one time or another, but there's some 7 or 8 young men reported in a cluster, and there was concerns, I can't even theorize, but there was concerns about the temporal relationship between transfusion for priapism and then a subsequent stroke within a week to 10 days. And so that's created some hesitance. Furthermore, for those who before then or even since then have said, but we got to do something, the transfusion treatment, like it might fix other things, may or may not actually help that particular complication of sickle cell acutely. So it's controversial about whether or not a blood transfusion would make a difference for them. And in the chronic state, it's not in the Lautenberg papers, I cited it, but there's been subsequent information. I have a couple of young women who take Viagra, which sounds stupid, but it actually has a paradoxical effect so that they retain sexual function to their satisfaction, they tell me at least. But the priapism, and it doesn't induce, like the ads say, don't have to climb in a bathtub and have a girl. It's the usual function for them, but it interrupts the pathophysiology of sustained unwanted erections. So, yeah, it's a tough sell to an insurer and even to a young man until you say, no, really? So anecdotally, there are some data about that.
And we have, a subset of patients that are on Viagra for the drug, and on Viagra for pulmonary hypertension.
Yeah, that's
And
in much higher doses.
yeah,
That's right. Yeah.
and we actually haven't had any problems with priapism in them.
That is right. It does not seem to cause that problem, despite what you might worry about.
We have a young man who's been treated with a combination of testosterone and cortisol.
Yeah.
And these changes, and it seems to have reduced the episodes of fibrosis. I'm not sure if these changes keep cortisol, but it's working. I mean, he was almost every night, every morning. He would have a certain amount of priapism, certain degree. But since he started on the protocol, he's been cut by more than half. I don't know if anybody's ever heard of it.
Yeah, actually, this young man was just started on ketoconazole by a urologist who had cited a paper, again, not in sickle cell, but we adopt or adapt when we don't have our own evidence, and so it's being tried. So, at least the ketoconazole.
And anecdotally, at home, one of my fathers taught me who had SC disease. He had a lot of problems with priapism. He's tried to go into the ER and have people poke needles in him. And to take his mind off it, he started doing sit-ups when he woke up with this in the morning. He found doing sit-ups helped it go away. So I think it might be a combination of exercise, working release, increasing circulation, maybe even some degree of manual pushing of blood in and out by bending of the waist. But he swore by doing sit-ups to help that go away. So our kids will tell them, get up, hydrate, try to pee, take your peeing medicines, do sit-ups till you're sweaty, then get in a nice hot bath. If it's still there, you probably need to come to the ER, but at least you won't be stinky when you show up.
And I do predict that would be a quality assurance measure about sit-ups, but go with what works. Like I said, swim with the current. It's an easy, arguably harmless intervention.
Maybe harder to do in the emergency room,
Yes.
but at home we'll try to have them do that for somebody who starts having
It's interesting that you have these young kids that you're trying to do phenylepinephrine injections, and they're already in pain. I find that I have to sedate most of my patients to do it. Any other questions? Okay, thank you.